I'm going to introduce our next speaker, is Dr. Ashok Malla. Ashok is based here in Montreal at McGill and the Douglas Hospital, and he's been a pioneer in developing early intervention services for psychosis in Canada. And recently he's embarked on a major pan-Canadian project to show how youth mental health services can be transformed in this country. Ashok?
Thank you, Ian.
Okay.
How do I get this slide? Okay. Yeah.
I notice there's a number of people that are standing, and there's many seats that are available right here in the front. So please, if you'd like a seat, just come up, and there's plenty.
Yeah, if you're on the outsides, just squish in a little so you meet your partner in the middle, so you have more seats, please. Whoop.
Thank you, Ian. Good morning, everybody. Bonjour à tout le monde. This place is really amazing. First of all, I want to congratulate the organizers who chose Place des Arts for this conference. I mean, normally, people like me, or probably most of you, are sitting there, and some very special people are out here. My most memorable time here is about 6 years ago. I was sitting somewhere there with my daughter, and on the stage was a 90-year-old man who could hardly walk to the microphone. But then when he walked back to the piano, it was magic, and that was Dave Brubeck. So this is a very special place, and I think we have a very special conference here, so this will be probably the other memorable thing about Théâtre Maisonneuve for me. I want to talk, obviously, very briefly about Access, the project that Ian referred to. And before I talk about the project, just want to give you a little bit of a history, very briefly. It is somewhat very particular. It's the first time in Canada, at least, something like this has happened, that our public funding research organization, Canadian Institutes of Health Research, made a partnership with Graham Beck Foundation, and at the same time, they were launching what is called the Strategies for Patient-Oriented Research. And probably for the first time, something new happened, and mental health actually happened to be the first project to get off the ground. So SPORE initiative is a huge initiative from CIHR. It's a huge change for CIHR, the way the research is normally conducted. And youth mental health happens to be the first project. The second part of it that was really significant is the financial partnership between CIHR and Graham Beck Foundation, each of whom put $12.5 million into this project. And there was a very detailed, long process of evaluation. There were 3 stages. It was as long as almost an elephant's pregnancy, which, by the way, is about 2 years. So at the end, through a competitive process, was born not a baby elephant, but Access. So what is Access about? Access is about more than just access. The acronym actually came through a very iterative process, and through the network that we agreed to, that the acronym and the name of this project should really reflect our values. And Access, in fact, stands for Adolescent Young Adult Connections to Community-Driven, Early, Strength-Based, and Stigma-Free Services. One of the first things we did in the network, even before we actually got the grant, in the process of building the grant, was to define what are our core values. And we really, I mean, I have learned a lot. I've been in this field for 30-odd years, but what I learned in the last 3 years is probably more than what maybe I learned in 10 years, but it's a different kind of learning. And part of that is, how do you build a network? How do you build partnerships that you don't just sit in an office with your fellow clinicians and researchers and design a research project? You do it in partnership with others, as you heard earlier. So we came up with these core values that ultimately defines Access. A culture of full participation from youth and families is one of our primary core values for this project. Recognition that a young person in distress is a whole person and not his or her dossier. one of the young people during our network meeting, an earlier network meeting before the project got funded, put it very, very nicely. And she said, you know, when I went to see the psychiatrist, he made me feel like I was the problem. And I told him, I am not the problem. I have the problem. Let's solve the problem together. And I think that's the kind of value that we like to reflect in our project. Sensitivity to social cultural values. We live in a country that has enormous diversity, both in terms of geography and culture. Easy early access to assessment and appropriate evidence-informed care, and design and delivery of mental health services from a philosophy of resilience, empowerment, and respect, and not all the time zero in on what is wrong, in what way is the individual disabled, but in what way is the individual able in other spheres. So Access is essentially a network where we have 12 sites across the country. And I'll just show you where, as you can see, they are all the way from the extreme north. The Uli, I actually don't like to pronounce it because I'll pronounce it wrong, so we all agreed we'll call it Uli. In the Northwest Territories, we have an adolescent youth mental health service in Edmonton. That's our large urban English-speaking site. An additional site in Edmonton, we have a vulnerable population, which is all first-year students entering University of Alberta. That has about 21% international students and another 20% from rural areas who left home for the first time. We have, in Saskatchewan, we have one of the sites is Sturgeon Lake, and it's part of the Federation of Saskatchewan Indian Nations. We have in northern Quebec a Nunavik in Puvis site, which is another Inuit site. We have, what happened to here? Yeah, okay. And in northern Quebec, we also have the Cree Nation site, Mistassini. And in New Brunswick, we have the entire province, which is sort of a demonstration site for small urban rural context. And in Nova Scotia, we have another indigenous site. There you are, you see. They are ready. They are ready to go. And in Montreal, Montreal is our other large urban site. We have Park Extension, which is a high immigrant population. About 40 to 50% of youth in there are of immigrant background. And then we have another site in Montreal, which is the Dans la Rue. It is another vulnerable population in downtown Montreal. And then we have the third site in Montreal, which is sort of urban but somewhat suburban, Dorval-la-Salle-Lachine, with a population of about 20,000 youth in that age group. And then we have Chatham-Kent, Ontario. There you are. Another site just ready to roll. And that's a site for the context there is, again, a small urban but largely rural setting. So this is the sort of the nature of our network. And these are all sites that represent, as you can see, a variety of contexts, both in terms of population, geography, culture, so that at the end, when we are able to produce the evidence, we don't have to go back and say, okay, well, does it really apply to indigenous settings? Does this evidence apply to rural? We'll have a sort of a heterogeneous samples to examine the effect of the transformation. Another important feature of this is from the very beginning, TRAM required, and it was a very, really amazing piece of requirement that we have to have so many stakeholder groups. Youth and families, according to TRAM, were put together as one, but we deliberately separated them because they may have very different issues, very different perspectives. So these are our important stakeholders, especially youth and families, obviously service providers in all of the sectors, policy and decision makers, community agencies, and of course researchers, and many of them double up. Many of us are service providers and researchers, and also in the other areas. So what exactly are we going to do in Access? What we're going to do essentially is two things. We are going to try to transform the way services are organized and provided in these sites, and then look at the evidence. Well, does it actually work? Does it produce better outcomes than we would have had otherwise? So here is the kind of a very brief formula of what we're going to do. We are aware that we really need to work with the current services. But it was made very clear, I remember actually Tony Beck at the time, this is now going back 4 years, 3.5 years, saying, we're not interested in tinkering with the services. We want a true transformation of the system. And that's what we are trying to embody in our Access project. But having said that, we still have to take into consideration the existing local youth mental health services in all of these sites. And our final product has to be a transformed, sustainable, local youth mental health service that takes into consideration the local context, the local culture, the local needs. But how do we get there? The first step is to reorganize the service that exists according to the Access principles. So we take the resources that are already there, reorganize them. We add to that several resources from Access, money, dollars that will buy human resources, expertise that comes from the network, not just from a few people, for the entire network, and that expertise is both learned expertise, like people like me, and lived expertise, people like Alicia and many people involved in our project, and then training and support. And I think this is one thing when there are transformations announced, especially by governments, so we're going to transform the mental health service. What always gets left out is how. Where is the training part? Where is the knowledge transfer part? And I think that is one area. It's a very large part of our project. So the Access resources will essentially add to the currently existing resources, which will be reorganized, represent the values that I talked about, and reorganize the service with the objectives that I will mention in a minute. Okay. What are those transformative elements and principles in our? Essentially, there are four. The first is early case identification. I mean, we know that one of the biggest challenges in youth mental health is untreated prevalence. In fact, it's much larger than the treated prevalence, even if you consider that the quality of the treatment really is not generally that great, and also the delay in people getting to treatment. So first objective is early case identification. How that will be done will be very different from, let's say, in Mistassini or in Eskasoni than it will be in Montreal or in Edmonton. So the methods that are available are locally contextualized, and of course the science that exists in early case identification will be used. The second will be rapid and early access, an open referral system in these demonstration sites, access to a qualified, trained professional to do an assessment within 72 hours, supported by a peer support worker, and in some places a family worker, and then on to appropriate care that has to be of high quality, evidence-informed. There is obviously going to be variation across sites of what those individual interventions will be, but in general, we know what works and what doesn't work. So we're not going to create any new treatments, but we're going to pool together evidence on interventions that exist and make it available in a new system. However, what we are doing in terms of whether they're assessment or intervention or treatment protocols, they're all being designed by or put together by working groups that have representation from youth, from family, and from people with learned expertise. And then the final objective of it is that there is there should not be a transition based on age. These services have to be continuous from 11 to 25 as long as the person needs the service. So that's the kind of overview of what the transformation will be. And of course, it is a project where we have to evaluate what we are doing. And in fact, one of the sustainable parts we would persist on is that there has to be a minimum evaluation as this project or other integrated mental health services for youth get scaled up, that evaluation, which often gets ignored, has to be built into this. So we're doing two kinds of evaluation. One for the sake of our research, which I'll go through in a minute very quickly, and one that can be sustained, that's a sort of a minimum assessment protocol that would not be too onerous, but that can be actually done and must be done in order to sustain the fidelity of what comes up as evidence. So we have, as I said, we have 12 sites. 6 of these sites will go into a randomized controlled trial, but it's not your traditional randomized controlled trial where half the people get it and half the people don't. These are actually communities that are going to be randomized. We have actually already done the randomization, and it's just the first 2 will get it, let's say starting in November. Then 6 months later, another 2 sites will get off the ground, and then a year later, the final 2. So it's a sort of it's a step-wedged cluster randomized controlled trial. So all of the communities that are in this controlled trial will get the transformation intervention, except that it will be staggered over time. And in the process, unlike traditional randomized controlled trials, we will be learning things along the process. So in the first wave, things we will learn, we're not just going to keep that, we're going to introduce that into the next one. And the evaluations will be done both in terms of before and after, as well as across the sites. The other 6 sites will be what we call special demonstration projects, where they're not going to be randomized, but they will have the same sort of transformation and a minimum evaluation. What will the research consist of? Just very broadly, essentially what we want to know is how and to what extent does access transformation meet its objectives. To give you an example, has it increased the rates of cases identified, and are the cases being identified earlier as the transformation proceeds? Does it provide youth and families and carers rapid, engaging access to mental health assessment and support? So inherent in that is that we're not only going to do quantitative research. It will be a mixed method, qualitative and quantitative research. We will be assessing whether there's an increase in youth and family care engagement in an active participation in shaping this mental health care. And at the end, how we actually improved youth mental health outcomes. And we are going to actually impress upon those outcomes that are particularly meaningful to youth, to families, and to society, and not just only rely on clinical outcomes. For example, how many kids are staying in school? How many kids are getting into work? How many people are able to support themselves, and so on. So the research protocol, in fact, I'm not going to go into any detail. Of course, we'll get socio-demographic information on. Then we'll have service level information, which will give us an indicator of was the treatment, for example, was the assessment provided within 72 hours? What proportion of individuals who sought service were offered to have a full assessment within 72 hours? That would be an example. We will be collecting these data both at the sites, and some of the administrative data will obviously be available from the provincial bodies. Each province collects a certain certain forms of data. We'll also be collecting data on satisfaction with services, especially satisfaction from youth and family care perspectives. Are they satisfied with their services? Again, this is obviously this will have both qualitative and quantitative perspectives. And overall, what we want to do is make this research and this project practical in a sense that the evidence that we have, first of all, midway through the project, we'll have a consensus conference. So the evidence we've collected, we're not going to wait to publish it and wait for 5 years. We will bring all our stakeholders together, policymakers and so on nationally, and share our findings. We will, in the meantime, we have already begun conversations with each of the provinces, because in Canada, health services are the responsibility of provinces. We have begun a dialogue in some provinces is much further ahead than in others of how do we scale this up when we're ready, or how do we create integrated mental health services for youth that are not just simply tinkerings of the old system, but that actually meet the objectives that I have outlined for you. So I will stop there, and thank you very much for listening, and thank you for coming to Montreal.